Okay, so I think we're going to make a start. Hopefully there will be more people joining us after lunch. My name's Adam Mather. I'm one of the interventional cardiologists at City Hospital here in Dubai. Sorry. So it's a pleasure for me to be able to address you today and to participate in this really exciting meeting. And the topic of the conversation today is going to be the management of dyslipidemia. So hopefully by the end of this next 25, 30 minutes or so, by presenting some of the evidence, clinical evidence, and some of the real world data, we'll be able to address and answer this question. Is there an urgency to prioritize dyslipidemia in post-acute coronary syndrome patients? So we'll start by highlighting the ongoing risk of ischemic events in patients who have presented with an acute coronary syndrome, because that is really just the start of the patient journey for them. We'll outline some of the evidence demonstrating the benefit of intensifying lipid-lowering therapies and the use of combination lipid-lowering therapies to improve patient outcomes after an acute coronary syndrome. I'll highlight some of the real-world data in terms of how well we are implementing the various lipid-lowering strategies that are available to us when we're treating the ACS population. And then finally, just focus on the latest international clinical guidelines on the management of dyslipidemia in post-ACS patients, hopefully just reminding you of the algorithms that we should be following when we're managing these patients. So what's the prognosis after a patient presents with their index acute coronary syndrome event? And the answer is not very good. So particularly if a patient's presented with an acute myocardial infarction, we know that there is an ongoing risk of recurrent ischemic events and major adverse cardiovascular events within the first, certainly 3 to 6 months after their index event and post-discharge, as well as out to 5, 6 years and beyond. So just patching a patient up in the hospital admission, looking at their coronary arteries and putting in a stent isn't the end of the story. And there is an ongoing risk in these patients, and there's much more that we can do to improve their prognosis after this index event. And if you look at patients particularly who have had a non-ST elevation myocardial infarction or an ST elevation myocardial infarction, that initial 3 to 6 months post-discharge from their index event is a very high risk period where there is a steep increase in the risk of major adverse cardiovascular events. So that was data, from more than 30,000 patients from the Alberta COAP study, looking at more than 30,000 patients presenting with an acute coronary syndrome. This is similar data from a national registry from Sweden, looking at nearly 100,000 patients who had been admitted with an acute coronary syndrome, and shows similar kind of outcomes, where in the first year after the index event, there's a nearly 20% incidence of a major adverse cardiovascular event, whether that's a recurrent myocardial infarction, ischemic stroke, or cardiovascular death. So nearly 1 in 5 patients who have had an acute coronary syndrome will have a further major adverse cardiovascular event within 12 months of their discharge. And again, similar data from more than 20 countries across Europe and Latin America, looking at nearly 10,000 patients who had been admitted with an acute coronary syndrome. And we can see that there is an increase in the cumulative probability of a major adverse cardiovascular event within the first 1 and 2 years after a patient has been admitted with an acute coronary syndrome. So there is clearly ongoing risk in this patient population. But is there anything that we can do about it? Does treating the patient aggressively at the beginning improve their outcomes? And this is data from the Sweetheart study that suggests that definitely there is. And so aggressive initial management of the LDL cholesterol does yield improvements in the long-term prognosis of a patient, such that the more aggressively you treat the LDL cholesterol within the first 6 to 10 weeks after a myocardial infarction sets the patient on a very different trajectory of future cardiovascular risks, such that the more aggressively we can manage LDL cholesterol, the lower the event rate subsequently over the next certainly 12 months and out to 5 years and beyond. So what is the evidence that we have for the benefit of lipid lowering intensification and the use of combination lipid lowering agents to improve the prognosis of patients post-ACS? Well, we know from various studies over the years that there is a clear correlation between the LDL cholesterol concentration and a patient's risk of atherosclerotic cardiovascular disease. And we know this from various randomized controlled trials, prospective cohort studies, and Mendelian randomization studies, such that the take-home messages are: the lower the LDL cholesterol, the better; the greater the LDL absolute reduction, the better; and the longer you can keep the LDL levels controlled, the better for the patient. So it's also about short-term risk as well as long-term risk. And over the past sort of 4 decades or so, when we have been using lipid-lowering agents, we've been progressively lowering the LDL target. And we know that as we lower the LDL target for our patients, we improve the cardiovascular outcomes for our patients. And if we look at the more recent studies of Improve It, which is add-on therapy to statins alone, Fourier and Odyssey outcome study with the use of injectable PCSK9 inhibitors, we can get LDL cholesterol levels lower than 50 milligrams per deciliter and still have incremental benefits and improvements in cardiovascular outcomes. So we no longer have to be fearful about lowering cholesterols to very low levels, because we know that the lower the better, and we will get incremental benefits in cardiovascular outcomes. So if we just sort of start on the journey of lipid lowering intensification, and the Prove It study was the first study to demonstrate that high-intensity statin therapy improves clinical outcome in ACS patients above and beyond moderate intensity statin therapy. So this looked at ACS patients, more than 4,000 ACS patients treated with high-intensity or high-dose atorvastatin at the dose of 80 milligrams once daily, versus then standard of care moderate intensity statin of pravastatin 40 milligrams once daily. And the patients were followed up to 2 years follow-up following their ACS presentation. And we can see nearly a 4% absolute risk reduction in the composite endpoint of major adverse cardiovascular events in the patients treated with high-dose atorvastatin. And that benefit started early and was seen out to at least 24 months after their index event. So this gave us the mandate really to be using high-dose atorvastatin in all of our ACS patients at the point of admission to hospital with their acute coronary syndrome. We then had the Improve It study. So this was the first study demonstrating clinical benefit in add-on therapy to statins. So this was the first trial using a non-statin agent, in this case ezetimibe 10 milligrams once daily, in addition to then standard of care simvastatin 40 milligrams once daily in the treatment of ACS patients. So it looked at more than 18,000 patients admitted with an acute coronary syndrome and randomized them to either receiving simvastatin 40 or simvastatin 40 plus ezetimibe 10 milligrams once daily. And again, what we can see is that there was significant reduction in LDL cholesterol lowering that was correlated also with an improvement in cardiovascular outcomes with a reduction in major cardiovascular event rate. After the addition of ezetimibe to therapy, we studied the PCSK9 inhibitors. So these are subcutaneous injectable medications. And the first one to demonstrate benefit in the acute coronary syndrome patients was the drug alirocumab in the Odyssey outcome study. So again, this looked at more than 18,000 patients with a previous acute coronary syndrome within 12 months of randomization into the study. So not started in hospital, but within 12 months of having an index acute coronary syndrome. Patients had to be established already on high intensity or maximum tolerated dose of statin, and that was either atorvastatin or rosuvastatin. And then they had to have at least one lipid entry criterion to be met. And that was either an LDL cholesterol of greater than 70 milligrams per deciliter, a non-HDL cholesterol level of greater than 100 milligrams per deciliter, or an apolipoprotein B level of greater than 80 milligrams per deciliter. Patients were then randomized on a one-to-one basis to either receiving alirocumab, subcutaneous injections, 2 injections per month, so an injection every 2 weeks, or an injection of placebo every 2 weeks. And again, what we can see in this study, it was a significant reduction in the composite primary efficacy endpoint of reduction in major adverse cardiovascular events. So cardiovascular death, recurrent MI, fatal or non-fatal ischemic stroke, or admission to hospital with unstable angina. And that was about a 15% relative risk reduction of the use of alirocumab on top of high-intensity statin, or at least maximally tolerated statin in the ACS population. And if we apply the Odyssey outcome data to kind of real-world application, we would see that if we use the updated 2019 European Society of Cardiology guidelines for our target level of LDL cholesterol in an ACS patient, which is an LDL cholesterol of less than 1.4 millimoles per liter, the addition of alirocumab in these patients would achieve an attainment of that LDL treatment goal in approximately 95% of all patients. Alirocumab has also been used, or at least its safety has been demonstrated in the early use of alirocumab with ACS patients in hospital. So the administration of the drug while the patient is still in hospital with their acute coronary syndrome event. Albeit a small number of patients, 20 patients with a type 1 non-ST elevation myocardial infarction and an LDL cholesterol of greater than 70 milligrams per deciliter, already, despite being already on high-intensity statin therapy. Patients were randomized on a 1-to-1 basis to either receiving one dose in hospital of alirocumab, 150 milligrams subcutaneously, or a placebo dose within 24 hours of their presentation with their acute coronary syndrome. And what the study showed, and it's just a safety study really, that there was a significant reduction in the LDL cholesterol within 72 hours of administration of the treatment drug, and significantly a reduction in LDL cholesterol at 14 days after administration of the drug. And this was well tolerated without any adverse safety signals. So just demonstrating that this PCSK9 inhibitor can be given in the in-hospital setting for potentially the extremely high-risk patient who requires significant intensification of their lipid-lowering therapy. Fourier was looking at evolocumab, so another monoclonal antibody PCSK9 inhibitor. The Fourier study didn't look specifically at ACS patients, but rather patients with stable cardiovascular disease, so maybe a history of a prior myocardial infarction, prior stroke, or symptomatic peripheral arterial disease. Looked at more than 27,000 patients. Patients had to have an LDL cholesterol, again, of greater than 70 milligrams per deciliter, or a non-HDL cholesterol of greater than 100 milligrams per deciliter on a high or moderate intensity statin at the time, plus or minus ezetimibe. And again, patients were randomized 1-to-1 to either receiving evolocumab or placebo. And the study, again, showed about a 2% absolute risk reduction in the composite endpoint of reduction of recurrent myocardial infarction, ischemic stroke, or cardiovascular death. But I reiterate, that's not in an ACS population, but the drug has been studied in an ACS population subsequently, and this is the EVOPAC study looking at about 300 patients with an acute coronary syndrome, and again, randomized 1-to-1 to either receiving a once-monthly injection of evolocumab versus a once-monthly injection of placebo, and demonstrating significant LDL cholesterol reduction at 4 and 8 weeks post-administration of drug, and that will yield an attainment of a target LDL cholesterol of less than 1.4 millimoles per liter in about 90% of ACS patients if we apply the ESC guidelines for the target LDL cholesterol in an ACS patient. So that's some of the data on how we use lipid-lowering agents in the acute coronary syndrome setting. But what's the real-world evidence of how well we're actually treating our patients and how well we're actually implementing what we already know? And the answer is we're not very good, unfortunately. And so this is data, European data, from nearly 3,000 patients who had been admitted with an acute coronary syndrome. And what we can see in this study is that only 67% of patients were actually discharged from hospital on a high-intensity statin. Similar data from non-Western European countries and non-US countries. So this is about 1,500 patients admitted with an acute coronary syndrome from countries such as Colombia, Hong Kong, Indonesia, Russia, Saudi Arabia. And what we can see here is that 52% of patients failed to achieve an LDL target of less than 70 milligrams per deciliter, and 81% of patients would have failed to achieve an LDL target of less than 50 milligrams per deciliter, despite being discharged on a maximum high-intensity statin. So 80% of these patients were discharged from hospital on a high-intensity statin, but less than half would achieve their goal, their target LDL cholesterol goal. And if we look at more global figures from the DYSIS-2 study, so this is a worldwide observational study looking at patients with chronic coronary syndromes as well as acute coronary syndrome. So this slide just focuses on about 4,000 patients who had been admitted with an acute coronary syndrome and demonstrates that, again, less than 40% of these ACS patients would achieve an LDL cholesterol of less than 70 milligrams per deciliter, which at the time of the study was their target LDL cholesterol. But even fewer, about 20% of patients, would achieve an LDL cholesterol of less than 55 milligrams per deciliter, which, as you know, is the current treatment goal for an ACS patient. And how do we fare more locally? In the UAE, for example, where we know that 40% of all deaths are due to cardiovascular diseases, due to the high prevalence of diabetes, obesity, smoking. Well, the DYSIS-2 studies suggest that we're not very good locally either. So from those data, 67% of patients on secondary prevention in the Gulf region do not achieve their lipid targets. And that, again, I remind you, is based on a target of less than 1.8 millimoles per liter, as opposed to the current guideline target of less than 1.4. And it's very interesting, if we look at that real-world data from the DYSIS-2 study, and if we then apply what the guidelines would recommend that we should be doing in terms of escalation of lipid-lowering therapy, it's very interesting to see how much better we can do and how much better we can treat our patients. So if we take the data and we follow a recommended algorithm of intensifying lipid-lowering therapy, so initially, if a patient is on atorvastatin 40 milligrams once daily, at least double the dose of the statin and maximize the dose of the statin. Then maybe add ezetimibe. And if the patient is still not achieving targets, add a PCSK9 inhibitor. If we follow that algorithm and a patient ends up on triple therapy of lipid-lowering therapy, we will achieve their LDL cholesterol target in 98% of patients. So there is no reason that we cannot achieve our lipid-lowering targets in our ACS patients, other than perhaps physician inertia a little bit. And if there's anything that we should not be guilty of, it's physician inertia. If we know the data, if we have the guidelines, it is incumbent on us to implement those guidelines, to check the LDL cholesterol on these patients, and to escalate therapy as early as possible following the index event, because we know that the earlier that we can achieve a lipid-lowering, an LDL cholesterol within the target range, we're setting a patient on a lower trajectory of major adverse cardiovascular events subsequently. So what do the guidelines actually recommend for us? So this is the 2019 European Society of Cardiology updated guidelines. And the first thing that we've got to do is risk stratify a patient. So the guidelines are not specifically for an acute coronary syndrome patient. They're for all patients with suspected atherosclerotic cardiovascular disease. But we're going to focus on the ACS patient, which takes us to the very left of the screen. Any patient who has had an acute coronary syndrome at any time in their history is a very high cardiovascular risk patient. Okay? So we can make that decision when they're an inpatient with us in the hospital setting, or you can make that assessment when you see a patient in the clinic. If they've had a previous history of an acute coronary syndrome, by definition, they are a very high cardiovascular disease risk. So what does that mean in terms of where we, or how aggressively we need to treat them? If you are a very high risk patient, we need to get your LDL cholesterol to less than 1.4 millimoles per liter or less than 55 milligrams per deciliter, and at least a 50% reduction from baseline. Okay, so that is the target for all of our ACS patients. Now, not in the guidelines, but alluded to in the guidelines, is an extremely high-risk patient, so above and beyond this. So a patient who has had recurrent acute coronary syndromes, despite being on maximally tolerated statins, should have an LDL cholesterol of less than 1 millimole per liter, or 40 milligrams per deciliter. And what kind of percentage reduction of LDL cholesterol can you expect to achieve with the various agents that are available to us? I think this is a really helpful slide produced by the ESC that really helps you to understand what you are going to achieve with the various drugs that are at your disposal and the various doses. So a moderate intensity statin is typically going to achieve an LDL cholesterol lowering of about 30%. A high-intensity statin may be about 50%. So we're talking sort of atorvastatin 40 or 80 milligrams, or rosuvastatin 10 or 20 milligrams. A high-intensity statin plus ezetimibe, you could conceivably expect a reduction in LDL cholesterol of about 65%. PCSK9 inhibitor by itself, maybe 60%. And then if we add a PCSK9 inhibitor and a high-intensity statin and ezetimibe together, we can lower LDL cholesterol by about 85%. So as we've seen already, there are very, very few patients who will not achieve their LDL target, no matter what it is, when they're on triple therapy. But it's a useful slide to have in your mind, to have in your clinic, to understand when you check somebody's baseline LDL cholesterol. So this is talking about all comers now, not just ACS patients. Check the patient's baseline LDL cholesterol, establish what risk category the patient's in, and then work out what the percentage reduction you need to achieve that patient's LDL target. And you might as well therefore start with high intensity approach, whether that's a dual combination therapy or at least just high intensity statin from the get-go, so that you're escalating as early as possible and achieving a patient's target LDL cholesterol as early as possible. Because as one of those slides suggested before, the sooner you can get the patient on the right trajectory, you are lowering their risk of recurrent events. So what do the guidelines suggest? And this is all class 1 level of evidence A. So in all ACS patients without any contraindication or definite history of intolerance, it's recommended to start with high-dose statin. So pretty much that means atorvastatin 80 milligrams once daily in terms of the evidence base, but certainly high-dose statin. If the LDL cholesterol goal is not being met after about 4 to 6 weeks, then we should escalate therapy by adding ezetimibe to their high-dose statin. And if the LDL cholesterol is still not achieved after 4 to 6 weeks, despite maximum tolerated statin plus or minus ezetimibe, then the addition of a PCSK9 inhibitor is recommended. And that's class 1 level of evidence A recommendation. Okay, so this is randomized controlled trial data to support this escalation of therapy. So this is a slide to just kind of, in your mind, understand how we should be managing patients who have been admitted with an acute coronary syndrome. One of the things we're guilty of, and one of the slides touched upon it, I didn't mention it at the time, is we don't even measure cholesterol when a patient's come in with their ACS, and we fail sometimes to measure it ever again. Patients either get lost to follow-up or it's just ignored, and this kind of treat and forget kind of approach is really not acceptable anymore, where we just put a patient on a high-intensity statin and then forget about it. And that's not acceptable, because we know that we can improve cardiovascular outcomes if we very aggressively treat their LDL cholesterol. So a lipid profile should be obtained as soon as possible after admission with their acute coronary syndrome. Lipid-lowering therapy should be initiated as soon as possible. Okay, so same day that they're admitted, they should be going on high-dose statin, atorvastatin 80, for example. And at the very least, we need to be reevaluating the LDL cholesterol 4 to 6 weeks or thereabouts after discharge from hospital. And at that point, determining if the treatment goals have been met, checking obviously for safety issues, looking at liver enzymes, etc., and then adapting the treatment algorithm as is necessary and as is appropriate for the individual patient. Now, a patient might be representing with a recurrent acute coronary syndrome, in which case maybe they're not just very high risk, they might be extremely high risk patient. They might already be on a high dose statin, in which case in these patients, it's acceptable and maybe appropriate to add ezetimibe in that second admission, if it is, or even consider in-hospital initiation of a PCSK9 inhibitor. And certainly, as I said, at the very least, we need to be re-evaluating lipid profiles 4 to 6 weeks after discharge, and then again, perhaps at 12 weeks, to see whether a patient needs to have further intensification of their lipid-lowering therapy. And some of the world experts in dyslipidemia have suggested that maybe there should be a paradigm shift now in terms of moving away from just accepting high-intensity statin therapy and this watch and wait paradigm, and instead treating all very high and extremely high-risk patients with combination therapy as the basic standard of care. So all patients admitted with an acute coronary syndrome perhaps should be started on a high-intensity statin and ezetimibe in their index admission, and then re-evaluating for the need for either a PCSK9 inhibitor, monoclonal antibody, or perhaps bempedoic acid, or one of the small interfering RNA molecules to help further lower LDL cholesterol. So this is just, again, focusing on the fact that any ACS patient is a very high-risk patient. Perhaps somebody with recurrent acute coronary events is an extremely high-risk patient. And in those patients, really, should we be considering statin, ezetimibe, and a PCSK9 inhibitor in that hospital admission? Because for those patients at extremely high risk, we want to lower the LDL cholesterol to less than 1 millimole per liter. So in summary, hopefully we've outlined that there remains a substantial risk of recurrent ischemic events after discharge for all acute coronary syndrome patients. The maximum risk or jeopardy appears to be in that first 6 to 12 months after discharge from their index event, but there is an ongoing risk. So an acute coronary syndrome identifies a patient of being at very high cardiovascular disease risk. Earlier high-intensity lipid-lowering combination therapy not only increases the efficacy of LDL cholesterol lowering, but also improves cardiovascular outcomes following an acute coronary syndrome, as shown by various randomized controlled trial data, such as the Prove It, Improve It, and Odyssey outcome studies. Real-world experience data tells us we're not very good at treating patients' cholesterol, and there is lots more that we can do to improve or to close the gap on this unmet need for our ACS patients, whereby intensifying their lipid-lowering therapy at an early stage and aggressively can improve the clinical outcomes in this very high-risk population. And that the latest global guidelines and consensus treatments propose a cardiovascular risk-based approach and recommend lower LDL cholesterol goals and early intensification and the use of combination therapies. And with that, I thank you for your attention, and we'll take any questions.